Welcome you all to the 77th session of the Weekly Huddle. I'm your host, Anoop Agrawal, and joining me today is my friend and co-host, Dr. Praneeth Pulamari. A lot of today's attendees are regular attendees of the Weekly Huddle, so I'll skip the introduction part. Today's discussion is a little bit off the topic. We typically discuss patient-related issues where, or I should rather say clinical relevant issues where we talk about management, diagnostics, and whatnot. But once in a while, we do talk about quality metrics, and we talk about factors which play a direct role in us delivering the care that we are supposed to. One of those topics that we are discussing today is about doctor-patient FaceTime. And this discussion, I think, is relevant because of few data points and also few experience points. And I'm sure that each one of you have your own experience and thought process about this particular topic. So 3-4 years ago, this was around the time when I relocated back from US to India. This news was pretty hot at that time. This article was published in British Medical Journal, and I have shared the link of it in the invite. So this article basically looked at the total amount of time that a doctor spends in front of a patient. So essentially, we are looking at the face time between a doctor and a patient across many countries. So it looked at a lot of developed countries and a lot of underdeveloped or developing countries as well. It gave us an average time that is spent. And I did put it in the invite that the average time for India was 2 minutes. There were a lot of countries where the average time spent was somewhere between 15 and 20 minutes. What was interesting was GDP per capita of a particular country directly correlated to the amount of time GP spent with their patients. It certainly had to do a little bit in terms of patient volume, doctor availability, and also the kind of reimbursement that doctors are getting. But whether it also relates to the kind of practice that we do, mindset, approach, and whatnot, that is something that I'm trying to discuss with the attendees today. And then there are few experience-based points. So I work in care hospital, and I did a back of the envelope calculation at some of the busy doctors that we have. And typically the numbers that I average out is about 4 minutes. So most of the busy doctors whom I know, they average out at around 4 minutes. And I'm not talking about GPs, I'm not talking about general physicians, I'm talking about as a general doctors, which include general physician as well as specialists. At least I am surrounded by the doctors where the average time spent is around 4 minutes. So I don't necessarily think that the BMJ article is too much off. It probably is a reflective of what we do. I also know the similar story in inpatients as well, where the admission list for doctors at times stretches 40, 50 patients, sometimes 100 and 200 patients. Whether that number at some point starts affecting patient care directly, because it doesn't require a fact check that a lot of us, we can't remember individual patient details once it is beyond a certain point. So it's something like I can vouch for myself that for me to remember details of more than 20 patients is very difficult at a time. So whether that starts affecting the patient care or not, I have heard of stories where there are hospitals where the admitting doctor either does not round or rounds once in every 3-4 days, just because of the sheer number of patients that he or she has to see. I remember during my training, my faculty used to say that you guys are blessed that these days you see faculty rounding every day. When we were a resident in our 70s and 80s, faculty would come once in a week just to sign the paper, and rest of it was all on residents. So some of these things are there, and whether they are actually affecting healthcare or whether they are there and we just have to accept it, and patients do get treatment. So till the time patients get treatment, it really doesn't matter how the structure of healthcare is. And that is what I'm trying to discuss today. So the questions that I'm trying to figure out is, for a doctor to practice, whether in outpatient or in inpatient, how busy becomes too busy now, where it starts affecting patient care? In our opinion, what should be the ideal face time that should be there between a doctor and a patient? And does it differ between a GP and a specialist, because they both are addressing two different aspects of patient care? Similar thing in inpatient, where the face time is less important than the ratio itself. So what should be an ideal inpatient to a doctor ratio for a busy practice? I'm not talking about routine. I'm not a busy cardiologist. I would love to, but I'm not. And is there a business index beyond which patient care gets compromised for a busy doctor? Is there a way we can figure out, based upon team, based upon how many doctors are part of a team, based upon what kind of support staff a doctor has? So is there a way we can identify an index and we say that beyond this, patient care definitely gets compromised because the responsible doctor is not able to, will not be able to give the importance that the patient, or the attention that the patient deserves? So is there a way we can try to figure it out? So complex scenario. I don't think that there is going to be a straightforward answer. And just to defend myself, I'm not looking for answers. I'm just looking for opinion. I'm looking for what my colleagues think about these situations, which aren't really straightforward. So I'll start with my colleague Praneeth. I'll ask his opinion about this topic. Praneeth, as you know, that we keep discussing about these things whenever we are sitting having tea together. Is it a problem? Am I trying to address something which is not broken? The current system, because it is working fine? Is there less to complain about? What is your impression? And if you do find some problem, what do you think is a good solution for it? Praneeth, you can take over.
Yeah, Anoop, very pertinent point. The questions you asked are also quite relevant, but I really don't know whether there is a good solution to this. Few of them, I agree with most of the points that you said, that a doctor who is seeing should have enough time, or it is his responsibility when he accepted being a consultant, that it is his responsibility to know about each and every patient who is admitted with him, and he spends good amount of time where the patient gets that feedback or that satisfaction that he's been taken care of. So and the 2 to 4 minutes probably for a follow-up visit may be satisfactory, but for someone where it is a new patient or where there are a lot of questions, this becomes challenging. And most of the time, that is where those doctors who can be available or who are able to spend some time probably have a better practice, I believe. And those who are busy probably have less satisfied patients. But still, the numbers do not go with this norm. But I really don't have a good solution how to make this thing. I was recently, or today itself, there was a paper article in Sakshi, I believe, where for a lack of population in Telangana, there are only 4 doctors available. So with this doctor patient ratio, this becomes challenging, where the demand is more and we have to cater it. And maybe unless the infrastructure is streamlined, where there is a good practice of patients going through a regular general physician followed by a specialist, and it gets streamlined, these things may be challenging. Because now, at least in city, I believe if a patient has chest pain, they directly come to cardiologist, and cardiologist is busy treating with those atypical pains, angina, non-angina, and lot of these things. So probably that is where the time gets wasted, versus if it is streamlined by a physician or a nurse or somewhere, then probably he can better dedicate his time and be more available. Similarly, for stomach pain, they tend to go to the consultant per se. And these days, there is this trend of patients getting themselves investigated with these packages and coming and getting their opinions or trying to clarify what they think of they making their own diagnosis. So I think if we can have a better system where it is streamlined, hopefully the time is effectively utilized, the quality of work may be improvised on these aspects. This is what I could think of, Anup.
Okay, let me ask few direct questions to you. If you have to design an OPD, how much time would you designate as a cardiologist to a new patient visit? You don't know anything about that patient. For a new patient visit, what do you think is the ideal time that should be designated?
At least 10 minutes.
At least 10 minutes. And how about for a follow-up visit?
Maybe 5 minutes.
Maybe 5 minutes. You think that within this time, on an average, you would be able to provide a reasonable care to your patients, right?
Yeah. So when I say 5 minutes of FaceTime with a cardiologist, by the time there should be an assistant, a physician assistant, or a nurse who will talk to this patient, screen this patient, and evaluate, answer those questions which they can handle, like drugs and diets and some common myths and facts. And as a cardiologist, I'm essentially looking at any red flags and adjusting them.
All right. So now you are talking about a modified FaceTime where a patient has a direct FaceTime with the treating doctor only for a few minutes, but the patient has a more prolonged FaceTime with multiple other healthcare providers, which may be nursing, which may be physician assistants, or which may be a resident or a junior doctor or something like that.
Yeah.
Right. Okay. If you think those things are not present, then you think this 5 minutes and 10 minutes, you think those are a reasonable targets, or you think that's cutting too many corners then?
Yeah, that will be cutting too many corners.
And one more question, and this is going to be a very generic question, but I still want to understand, if one doctor practices by himself or herself, what would be the ideal inpatient to a doctor ratio?
Inpatient, I believe probably 20 to 25 should be something which will be a very good load for him. Anything which is going more than that will be overwhelming, and it might affect the patient care, in my opinion.
Is there a way for you to assess a doctor's business in terms of saying that this doctor is too busy, that it is affecting patient care? Is there a way by which you can assess that? Is there a tool you can use?
Not at this point of time, Anup. I'm not able to think of anything at this point of time.
Okay, perfect, Praneeth. We will get back to you with more questions. And because we have a little bit shallow attendance this time, I will keep the forum open for anybody to unmute themselves or raise their hand and whatnot. So few things. Doctors are always blamed for bad handwriting. And the whole issues of, let's say a patient comes to me with chest pain. I keep talking chest pain because I'm a cardiologist. Then we all talk about defining chest pain and defining a treatment algorithm for that patient. Well, the issues of establishing a patient rapport, discussing or showing empathy towards the patient's illness, talking about ancillary treatment or maintenance of care like vaccinations, lifestyle, and whatnot. I believe if we discount all of these things as, forget optional, as non-existent in a clinical practice, then I probably can address only chest pain in a few minutes. And again, the question comes that with the given time frame, like Praneeth is saying, he has got 5 minutes with a follow-up patient. If in the follow-up, the only discussion that we have to address is how's the patient doing and what the medication adjustment that we're going to do, then probably 5 minutes is a reasonable thing. But if we have to address what we as a doctors are supposed to do, which includes few of the things that we talked about, which is proper documentation, understanding patients' collateral issues, which may not directly be related to heart, showing empathy towards the illness, understanding the background of what patient is doing. Sometimes they have caretaker responsibilities, sometimes they have multiple other issues. And then talking ancillary therapy like vaccinations, like road safety, patient education and whatnot. Then I think we'll be stretching. Then I think that 5 minutes may not be sufficient. Whether in Indian setup where doctors are already scarce, whether those things should take a priority in a OPD, I don't know. And that is what I think we should discuss as a part of it. Am I being too idealistic? Am I being too purist when it comes to healthcare? Or we think that this is the fact of it, this is a practical way of managing a patient in India. I remember there was one time I was in discussion with one of the cardiologists about introducing telehealth. And I raised the question of patient privacy. And my colleague cardiologist very appropriately replied to me, I'm not putting him under the bus. I'm talking about his appropriate reply, which I agree to that, where he said that Anoop, in India, patients don't even get access to the doctor, let alone privacy. So let us talk about access to doctor first. We'll talk about privacy later. And I certainly, to some degree, I agree to that, for the lack of privacy, we cannot not do telehealth, because then in search for ideal setup, we may not even provide a basic setup. But guess what? Most of us who are in today's discussion, we are all privileged. We are in a privileged position where we are working in a private setup where we can demand and raise the bar of how healthcare should be practiced. So I think it is relevant for us to at least set the stage where other people can look at us and follow. So with that, I'm just trying to justify why I think this topic is relevant for us to discuss. And I'm inviting any comments or any suggestions that any of the attendees may have. A general question that also can be addressed, and any one of you can chip in, is as a general, do we think that we are giving enough time to our patients? And you may not have to answer for yourself, you may answer for people whom you see around. And secondly, what are the tips and tricks that you have incorporated in your practice where your work is efficiently done and at the same time patient gets enough face time or enough value when they come and see you? If you have any tips or tricks or anything to share, you are welcome as well. I see a few of the names here. Dr. Kanaya is there, Kirtika is there. I don't know, Dr. Shiva, if you could introduce yourself, Dr. Venu, any one of you, if you can unmute yourself and share your thoughts about today's topic.
Hello, sir.
Yeah, hi, Kirtika.
Hi.
Yeah.
Sir, such a nice topic, like one of the most important thing, which apparently we are neglecting. Not only like in the OPD, even while doing procedure also, I think I'm, compared to my learning phase, we are doing a little faster. Like we are not spending enough time with the patient, sir, which all the so-called senior physicians who are like well respected, they spend a lot of time. Not only they have good clinical skill, but also that aura what they give, like it's very much important. But how to improve it? For that only I'm also waiting, like you, Praneeth sir, can share some.
Right. Thank you, Kirtika, for bringing that up. You know, the reason why I'm asking my attendees to give their opinion is because if me and Praneeth share a lot of thoughts, so if we only just keep giving our thought, it's going to be a monologue rather than a discussion. So I'm really hoping that people who are logged into this meeting, they will open up and share their thoughts and concerns. And believe me, this is going to be a very casual discussion. Nobody is going to remind you later on, asking you why you said what you said. And I'm sure that you won't be saying anything worse than what I'm trying to propose. So please feel free and share your thoughts in whatever form. If you think I am being too purist, please feel free. If you think that what I'm raising is very relevant and how to improve on it, rather than just complaining about the problem, I think that will be quite relevant as well. Salma, if you can hear me, Salma is a senior nursing staff who works with us. Salma, what is your thoughts on it? As a general, you have worked with a lot of doctors. You think that doctors can spend more time with the patients, or you think this is what you have seen around you is reasonable, and that spending more time is not going to translate into better care? What is your thoughts? And then Swapna, I'll come back to you as well. Salma, please go ahead.
Yeah, good evening, everybody, sir. So for one thing is, yes, of course, like having a team would obviously add up in some good addition of value. But, our experience, like whatever we have seen, like whichever doctors I worked with, the patients will always have, might be because of the Indian setting or whatever you call it, but patients would always have, will have a better feeling when the doctor spends a little more time. Or if the doctor has a team which has been working with him for quite long time, and the patient develops that faith with them that, like, if something is communicated to the team member and it reflects the same idea, like communicating to the team is equally the same like communicating to the doctor, it's only then that the patient feel the value addition. Otherwise, many patients still feel like, even if they speak to us.
Okay, Salma got disconnected. Salma, we got your point. If we have a established team that patient can connect to, that patient. So basically what you are saying is establishing surrogates. We cannot create
Yes,
clones of ourselves, but we can create
yes,
surrogates of ourselves, right?
Yes, sir.
I believe that is what you mean to say.
Yes, sir.
So if we as a doctor, if we can identify surrogates and we can explain to the patients that our surrogates will perform at the same or better level than what we are, then now we will be surrounded with multiple surrogates who can make your work more efficient. And
Yes,
you may not have to spend that much face time with the patient, right?
Yes.
Okay. All right, Salma, that point is absolutely well taken. It certainly will work with returning patients who know how you work. For new patients, there still is going to be a little bit of challenge to understand. Having said that, we still have to figure out, like, see, I have seen both parts of the world. The place where I got trained, even my most senior physician or most senior doctor, even his time slots were same as mine. So even he had the same time slot for new patient and for old patient as what I had. And he certainly was working with a much bigger team than what I was. And the idea there was that doesn't matter whether you have a working team or not, you still need to spend at least this much face time with the patient, because whether you have done your work or not, that patient deserves to at least spend that much time with you, because that is what he came in with. That is what he or she considers value addition in there. Having said that, we don't have to practice what Western medicine teaches us. We certainly have to modify what we are doing in India. Swapna, you are working in AIG. What is your thought process? You have worked with so many doctors around you. What is your thought as a general?
A very good evening to all, sir. And here comes a qualified physician assistant role, sir. And the success of EP team is mainly the teamwork and also the physician assistants, which almost, for example, a new patient takes 20 minutes time, 10 minutes the physician assistant screens the patient, 5 minutes the doctor counsels, the next 5 or 7 minutes again the other physician assistant will counsel. So the patient is satisfied. At the same time, the physician or the consultant workload and the time what they have to spend will reduce. In that way, our consultant are able to see many more complicated patients in the same allotted time, sir.
Perfect. Thank you so much, Sapna. I think what you are bringing is also very relevant. I'm going to mute you because there is a lot of cross noise coming from your end. You brought up the subspecialty of electrophysiology. I would just say this probably holds true for very, very niche subspecialty setup where you have got a more or less well-defined patient structure that you are dealing with. And because you have a well-defined patient structure, you can get a team and assign roles to each one of them. And essentially it's like a assembly line in a factory where things vary a little bit, but for most part, they are working in a similar structure. And their patients serially go from step 1 to step 2 to step 3. So while the senior physician does not have to spend that much of time, the patient effectively gets the care that he or she deserves or he or she came there for. For a slightly less defined program, for a slightly less defined specialties like general physician or internal medicine or a general cardiology, for example, where when a patient comes, unless a doctor screens that patient, you don't know what kind of needs those patients have or which direction that patient has to go. This kind of assembly line approach sometimes may not work that well in those regards. And that is where I think as a physician, you end up spending more time with the patient, or at least you should be spending more time with the patient, whether that actually happens or not. That again is something which is challenging. But Swapna, thank you for that insight. That is absolutely well taken. A lot of us who work in that kind of setup, we certainly can create a microsphere around us where we can define individual roles so that at least patient care does not get compromised. And I'm guessing a similar thing can be done in an inpatient setup as well, where let's say you are a surgical practitioner or whatnot, where you know most of the patients follow through the same channel, through the same routine. So there also defining roles become a little bit more easier. Anybody else has got any other thoughts or comments about what we are discussing today? Somaraju sir, you can also see that there is a lot of apprehension about discussing or addressing this particular topic that I'm trying to speak out for. You have been in this business for eternity. Do you think in the Indian setup with the kind of practice that we are doing, are we spending enough time with the patients, so much so that we are compromising care? Is there a better way to handle this? And I'm not talking about the government setup, because in government setup, we know that as a general, doctors don't spend more than 2 minutes out of sheer volume. A lot of my colleagues who practice in Indian government setups, they see approximately 100, 120 patients in a 4-hour duration. That includes their bathroom break as well. So it's no way possible for them to spend more than 2 minutes per patient. So I'm not talking about that aspect of it. And no matter how much my colleagues try to defend saying that they are practicing good medicine, I do not believe that no matter how smart of a cardiologist I am, I am able to see, analyze, prescribe, and advise a patient within 2 minutes. I don't think that is possible. But for the private setup, for the kind of practice that we are doing, for the kind of people that we are surrounded with, and over a period of time, what do you think, Somaradu sir? How are we working? How have you designed your work? And going forward to kind of young to middle age doctors like us, what would be your suggestion how to go forward?
Thank you for asking me, and I'll come back to what I went through in my practice and what I do in the recent times. And having said that, let me also just bring out that somebody wrote in BMJ or somewhere about Indian doctors and the time they spend. But overall, doctors all over the world, that includes even US, the amount of time spent is one component. Thanks to insurance, even in US, if you spend more time than is prescribed, you are questioned today. That is an interesting aspect of US healthcare today. And having said that, whatever time the patient or doctor spend with each other, there was a study done in US actually as to how much time the doctor was listening to the patient without interrupting. That came at 8 minutes some time ago. That was a long time ago. And then people were not willing to believe that it was so short. And then a study was repeated. Then it was found that it was only not even 5 minutes now. In the recent times, this was done in US. So that is the state of affairs. So as I say, the healthcare delivery, I'm not talking about medicine overall, but healthcare delivery is an interesting problem in the sense problems are classified as simple, compound, complex, and wicked. The healthcare delivery comes under wicked problem. There are each component of healthcare delivery has enormous issues, enormous problems. Doctors and their time and they spend and the time they listen to and how they deal with people overall and patients overall there are a lot of issues. And I'll request others around to speak more. And if they have any questions specifically as to how I do it and how I plan to do it, but how I fail to do it and how I am doing, I'll talk about it as time permits. Thank you.
Thank you so much, sir. I'm fascinated by the studies that you have brought, and truly speaking, I would challenge the attendees who are here and I would request them that please do this. Sir, you are quoting that study. That means you have read that study and you are a full-fledged working clinical interventional busy cardiologist along with administrative work and everything. I urge my colleague cardiologists, physicians, nurses, and everybody that please spare part of your time learning about things which are related to healthcare, but not necessarily the clinical medicine part of it. Not everything has to be heart attack, or not everything has to be COVID, or not everything has to be pneumonia. A lot of it has to be healthcare systems, how services are delivered and whatnot, because a lot of the times it gives us far more insight than learning more about the new treatments of pneumonia. That is also important, but this is also important. So Somaradu sir, coming back to your point, actually, the way they did the study was they installed cameras with permission, of course. And what they did was they were trying, because in US, the way the OPDs are designed, and that is across the US, that there is no physical barrier. That's the basic structure rule over there. There cannot be a physical barrier between the patient and the doctor. So you know how so many times when we see where there is a table and doctor is sitting on one side of the table and patient is sitting on the other side of the table. That kind of design cannot happen in US because of the basic rule. The basic rule in the hospital is you cannot have a physical barrier. Now the problem is doctors also in the EMR world, doctors also had to look at the computer to look at their history and whatnot, just like how we are looking at papers for our patients. So now for a doctor, he or she has to look at the computer and also has to look at the patient. And because they both are not in the same line of sight, because there is no barrier, I'm just trying to paint a picture where a doctor is sitting, patient is on one side and computer is on the other side. In that scenario, a doctor can only look at computer or the patient at any given time. He or she cannot look at both the sides at the same point. That just cannot happen. So what these guys did was they put in the camera and they started recording how many minutes or what are the time that a doctor is looking at the patient rather than looking at the computer. And that was in the world of EMR, where the EMR was getting bad name, and I think it should get bad name, for it being more of a billing platform rather than a patient care platform. And what you said is absolutely correct. What the study did find was a lot of the time that doctor was spending with the patient, it wasn't necessarily a FaceTime. A lot of that time doctor was spending looking at the computer rather than talking to the patient or looking at the patient. These kind of thing can be taken similarly in Indian setup, where we can look at how much of time we are spending looking at papers or writing prescriptions, then talking to the patient. It can be a similar situation. And truth being told,
Anoop,
yes, sir.
sorry to interrupt. Today it is even answering your cell phones while talking to the patient. There is a common occurrence now.
Yes, absolutely. Absolutely. I think this is something, unless there is a medical emergency, this is bad. This is absolutely bad. I remember when I was in my MBBS, my cousin brother had to get an endoscopy. I'm talking about year 2004. The gastroenterologist, while doing endoscopy with the scope in his stomach, and I was standing next door, I was an MBBS student, I didn't know anything. His phone rang and he picked it up. So he picked up the phone. He spoke on the phone for about 3-4 minutes, which at that time felt like 15 minutes, while the scope was inside the patient, who happened to be my cousin brother. So I totally agree with you. I think that these things, they cannot add to so-called patient FaceTime. A patient may be in the room for 15 minutes, but doctor may have given only 1 minute or 2 minutes to that. This is a rampant problem in the United States. But even then, I'm not trying to defend US, but even then, I think that enough time is spent directly between the patient and the doctor than what we are seeing in the Indian setup. For us, the computer is akin to the papers that we are flipping, the book that we are looking at, the prescriptions that we are writing. Remember, in US, a lot of the prescriptions and orders are done offline, which means you leave the room, then you go and sit in your cubicle where you write the orders and when you write all of this. So that does not become a part of the FaceTime. A lot of doctors, they actually step out of the room to write the orders and to write the notes and whatnot. In Indian setup, because of the logistics, because of the paper for most part, and EMR with us is not well defined, we do it everything in front of the patient. So while a patient may be getting 10 minutes with us, our FaceTime is not more than a minute or two. In fact, I will share something very interesting. And this is, I have not done a randomized study for it, but I'll share something very interesting. Whenever a patient comes to my room with chest pain, and I know that chest pain diagnosis 95% of the time is history only. The moment a patient comes with the diagnosis of chest pain, with the history of chest pain, I turn my stopwatch on with a 2-minute timer. And I tell the patient, you have to speak for 2 minutes. I'm not going to interrupt. And for most part, it leads to an awkward silence where the patient speaks for a minute. And I have already committed saying, I'm not going to open my mouth for 2 minutes. So for literally 1 minute, we sit there in silence. So many times, what we think that we are giving 10 minutes to the patient, I can challenge that our FaceTime to the patient is literally a fraction of what we are talking about in the Western world or whatnot. They're no better in terms of clinical providing that clinical care that we are doing. But that FaceTime issue is still a big thing. My biggest problem is The patient is spending 2 minutes in doctor's room, let alone FaceTime. Average encounter that doctors are having is 4 minutes, 3 minutes, 2 minutes in BMJ. Even if we are giving 100% of the time as our FaceTime, which is not possible, still we are talking to the patient for about only 2-3 minutes. Whether that is affecting healthcare or not, I don't know. And that is the discussion. Okay. So, sir, we heard you. If we have any specific question, we certainly will come to you. We have Dr. Gauri joining us. Dr. Gauri, this is your forte. Tell us. I'm sure that you have a lot to add about it. GPs, specialists, outpatient, inpatient. How are we doing?
So, hi, good evening, everyone. I'm really sorry I have joined in very late. I was actually tied up with something, but I mean, this is a discussion that we can go on and on. I can tell you what I do, and I'm not sure if it has worked, but it seems like it. And I agree with whatever I've heard that yes, the true face time which a patient gets is much lesser than what the patient is actually there in my cubicle, right? So. So few things that at least I do, which help me in building that rapport with the patient and then ensuring that whatever time that I'm giving, you know, it may not be complete face time, but whatever time that I'm giving to the patient, it's of immense value that I provide through that time that I'm giving, right? So that is very important. So the first thing that I do specifically for every patient who is coming into my chamber is that I ensure that I walk out of my room and get the patient in, right? That's the first thing that I do. Because my FaceTime starts outside the clinic, my chamber room, rather than inside my chamber room. And that itself adds a lot of value. Now, within the chamber room also, when, as you rightly mentioned, I think the first say 90 seconds of the maybe first say 10 seconds of the conversation is, of course, introducing yourself if the patient doesn't know you. But otherwise, the first 90 seconds is usually 90 seconds to maybe 120 seconds is usually left to the patient to talk, if he or she has to say whatever they have to say. Because it is right, some patients would want to talk for more than that. Some people talk less than that. But on an average, I have seen that most patients, at least in my chamber, tend to talk for say anywhere between 1.5 minutes, like a 90-second to a 120-second period, right? And because that is the time that you see a lot of things that the patient wants to show you, even before you start asking any questions. I specifically know that there is a disconnect with the patient when I'm writing or typing. Now, as a medical professional, I have over a period of time learned the art of typing. You know, it was never taught to us. That was something which was, I think it has become now basic, and people, graduates who are currently studying, this is one of the skill sets that they should be provided, that everybody needs to know typing, because the fact remains that at some point in time, when the EMR systems are here, technology is here, so we will have to adapt to it, right? I mean, we can't do away with it. So what can we do to ensure that it is not becoming a hindrance for us? Definitely learning that skill. I have said over a period of time, I have learned the art of typing while not looking at the screen, right? Over a period of time. I mean, it's not that it's the perfect thing to do, but it does help if we build that skill set in ourselves. Second, it is absolutely all right to tell the patient, and I do that very clearly, even if I'm writing on a paper or typing, that there would be times in between that, I may not be looking at you. However, I am giving you 100% of myself. So when I actually express it to the patient, I think that also works, because I am consciously then making an effort to be available with the patient and not really with the typing that I'm doing or writing that I'm doing. But both are happening simultaneously, and with more attention given to the patient at that point in time. If I express it explicitly, the patient understands it also, and I am making myself aware about it as well. So I think, this is something that I do to help ensure that, there is the break in the kind of relationship that you're building is lessened, in that sense. The major part of the consultation is really spent in the management plan that you're making for the patient, whichever, and I know that there are patients who sometimes take just say anywhere between 7 to 10 minutes. I have had patients who take like 30 minutes, even more as well. So it really depends on how I then, over a period of time, because appointments are blocked and you have follow patients, you realize which patient is coming at what time. And actually speaking, I have taken the liberty of changing appointments by making calls to the patient and telling them that, I would want you to come early on, or I would want you to come later on, so that, because I know that this patient any which way invariably ends up taking more time. Because in my chamber, I usually see repetitive, like the repeats are very high, right? They keep coming back again and again to you. So then you know the personality of the patient also, and then you know how you are going to settle yourself around that patient's behavior, or around the patient's, the way I would want to operate around a particular patient, right? According to their needs and their behaviors, like that. So I have taken the liberty, and it works if you are very frank with the patient and tell, I would want to give you more time, and I would want you to come at so and so time, which may be at the end of the practice or at the beginning of the practice hour, so that, I would want to either finish it off or figure it out a method to, lessen the timing, or, you can work around it. But I think that works for me, because patients could be repeating again and again. And that makes me understand which patient needs to be given how much time. However, any new patient, definitely, I end up giving them anywhere between 10 to 15 minutes of my time. And I usually would not block more than, say, 5 consults an hour, because especially for a new patient, I will have more time than a repeat patient who's coming in, unless the repeat patient requires more time, as understood by me and the patient's needs, that way. In terms of, charging, I have done this in my chamber and it has worked, wherein we, at least in my clinic, they always upfront payment happens, which happens in most hospitals now as well, that the patient pays first for a consultation and comes in. So that happens in my clinic also. But what happens is, if I see that this patient is taking longer than, the next patient appointment, I have taken the liberty to tell the patient that, there are other patients waiting, and would you mind blocking another schedule through the, if there is if there is a particular slot available, so that I can continue my discussion with you. I have done that. Most patients kind of agree to it. There are patients who do get irked by it as well. But either which ways, because I think time is important. If I am giving I'm there on time and I am giving that time, I think most patients also, at least urban, I again cater to a small population, which is urban, typical middle class, right? So lower upper middle class, that kind of a population who do understand that time is important, and they do, if told very clearly, they do, wait. Otherwise, I have employed, interesting ways in which the receptionist knows that she will call in and say there are patients waiting, so that we can curb or shorten a consultation, depends on, if there's a ranting patient, or a, what we call as heartburn patients, who really take a lot of your time. But I think the nutshell is that you need to know the personality of a patient. Especially with repeat patients, this can work wonderfully. With new patients, yes, it can be a little difficult, because the patient doesn't know you, you don't know the patient. So it becomes sometimes an issue. Yeah.
Dr. Gauri, I have a question for you.
Yeah.
So I certainly think it is fair to charge a patient more if the patient is needing more time of yours. I think that is absolutely fair.
Yes.
Does it work the other way around as well? If a patient comes with whom you are done within 2 minutes, does that patient, do you refund half of your prescription fee to that patient, saying you had a 10-minute slot, but we got done in 2 minutes? I'm just giving you a hypothetical scenario.
It has never happened to me. It's usually the other way around. It has never happened that I have finished with a patient early on. Usually, I don't know, maybe it's my problem, I guess, but I never tend to finish a patient early on. It's always usually extending. Principally, yes, it sounds right. to refund them back, but I think there is something called as minimum payment that should be done for a particular reason, for a particular specialty or a particular thing that you're coming to a doctor for. And it is perfectly right for a doctor to charge at least a minimum fees for whatever time, for the knowledge expertise that the doctor brings in on the table, right? Otherwise, the patient would not come to you, even if it means 2 minutes or 10 minutes or half an hour or 1 hour, right? The patient has come to you because of the expertise that the doctor has. So there has to be some minimum payment that the patient has to provide. I believe that is the right thing to do. But yeah, principally, if you want to think, oh, it is time based, I don't think we can judge. We can only take it as time based. It's not like for a 1 hour drive, a patient, if somebody is charging 100 rupees, then for 2 hours it becomes 200 rupees. It may not be so all the time. Again, to understand that charging extra for a patient is not for every patient also. Like I also believe that there are certain patients I don't charge them more, right? Because they truly needed that. But there would be certain patients that you would want to charge them more because they have kind of spilled over a time where, where maybe they might not have required that, but they just took your time, right? So in my opinion, I may want to still go ahead with having a minimum payment, which a patient must give, because of the knowledge that they are coming in here for. They are coming here for an expert opinion. They're not coming here just for, time-based something, right? So,
that is absolutely valid. And this is exactly the kind of discussion that I'm having today. Minimum pricing for a minimum value. That's the minimum value that we should be providing. And the question here is, are we providing that minimum value in that 2-minute conversation? That is the whole idea behind.
Absolutely. So that is exactly what, right? That who decides the value, right?
Exactly.
I mean, doctor, I would say it is at the end of the day, is the end consumer who is deciding what is the, a patient may never be happy even if you give a 1 hour consult. A patient may be extremely happy with a 5-minute consult also. It really depends on the end user of what his or her experience is about it. Now, there are two things to it. The outcome of a consultation is A, based on what the patient feels at the end of the consultation, and B, the actual clinical outcome, what happened, which cannot be measured at the end of the consultation. Clinical outcome cannot be measured at the end of the consultation. It has to be measured when actually the medicines were taken or whatever was done. It takes its own time, right? Clinical outcome. So how do you measure that, right? So measuring that would be based on what the patient feels at the end of the consultation.
Right. I think that it certainly is. Your point is well taken. This is difficult aspect to even understand the value that we are talking about, how to quantify and how to analyze whether the appropriate value has been delivered or not. Prashant, you joined in a little bit late. Do you want to share your thoughts about the topic that we are discussing? Dr. Prashant?
Hello.
Yeah. Hi,
Good
Prashant.
evening, everybody. Hello, sir. Yes, sir. I joined in late. I was listening to the discussion which was happening. It is very interesting because on one hand, I am an interventional cardiologist, and other hand, my father is a physician. Till today, he sees patients for half an hour. So he sees only 5 patients per day. And on the other hand, I am there who I'm just seeing for, as we are discussing, like 2 to 3 minutes. And after 5 minutes, I am like, I have another patient. So we are two extremes living in the same house, and this discussion is happening every day at dinner that how are you still seeing so I cannot be like seeing so many patients, like so much you need patience and all that. So this I have been listening to this since my MBBS days, and it is very interesting to hear about so many views which Dr. Gauri was saying, so many facts he was telling, and tricks he was telling, that how to engross the patient, and you were telling about stopwatch, that thing. So yes, it is needed. So we need patience, and many times extra time is consumed by the patient, but I don't think it is right to charge the patient. But yes, we can just hush them up and finish them quickly. But most of the things which I heard, sir, was good. Like I learned a few things. Thank you, sir. Nothing new to add from my side.
Thank you, Prashant. So there are two things again that I will share, and I keep bringing what Western world does, because that is the only experience I have, and I really want others to share their experience as well. So I'll just share my experience. Number one is about billing. So, in US, it's a standard thing for OPD that you bill at 5 levels. So you bill level 1, 2, 3, 4, 5. And those 5 level billings are very categorically described. There are rules for it. You cannot commit fraud. You cannot over or under bill. So essentially, when a patient comes and you provide them the kind of service, you become the judge of what kind of service you have provided, and you bill the patient accordingly. So you can bill a patient as level 1 service or level 2 service or 3, 4, 5. So there are patients at times who require more than the designated time slot. Let's say a patient comes into your OPD, you are a general physician, patient comes to your OPD with chest pain. You immediately do an ECG, diagnose them with acute MI, call an ambulance, call the emergency, send the patient to nearest ER. So you have spent a lot of time in coordinating that patient, less time in diagnosis, because diagnosis happened within 5 minutes. So in these kind of patients, because you have spent a lot of time coordinating, you bill them level 5, saying that you have spent a lot of time in coordination. There are at times when patient comes in with symptoms where you have to take a 10-minute history to come to a diagnosis. There you bill them level 5 because you've spent 10-15 minutes just understanding the problem. These things are standard practice in US. To have something like that in India, I still struggle. I don't know of any better way of doing it. But Dr. Gauri says that there are at times where she tells patients to book another slot to do the discussion. I sometimes tell the patients to book another slot for continued management of health, like vaccinations, lifestyle measures, and whatnot. So a patient who comes to me with an acute visit, like a problem, I address their problem and I tell them that I do want to talk about your lifestyle and your risk factors and your vaccinations and whatnot. But because in this visit we addressed acute care, make a second appointment and there we'll talk about not your acute problem, but about all the other stuff. But I do tell them that every single time, if you come with the acute problem, then we'll address the acute problem, not the other aspect. Whether that is fair or not, I don't know. If I were in US, I were told you have to address everything at the same time. You just bill them level 5. So whether that is something which is possible in Indian setup or not, I don't know. And I'm sure there are various ways. The second thing that Dr. Gauri also mentioned is about learning how to type. And again, I'll share one experience which I witnessed in the Western world. Over there is a concept of medical scribe. A lot of you know already, I'm sure Dr. Somaraju knows, and a few of you who may not know. So I'll just explain to you what medical scribe is. Medical scribe, it's spelled as SCRIBE. Essentially what it means is you have a partner with you, and that partner typically is a medical student. Sometimes it's an MBBS pass out, sometimes it's an expert nurse, but for most part, it is somebody who is directly related to clinical care. So you have a partner with you who walks with you as your clone with a computer in their hand, because in US it's EMR, in India it could be a book or an OPD prescription book or whatnot. So they walk with you with a computer in their hand. And every time you speak to a patient or you tell your plan to the patient, if you tell the patient, we are going to check your hemoglobin and we are going to do an X-ray, what medical scribe is doing is as you are talking, that person is translating your words into the computer. So if you say we are going to do X-ray, that person is actually entering the X-ray order right there. If you are taking a history of chest pain or whatnot, that person is actually making notes, entering in the computer that chest pain patient complained of this, and whatnot, and blah, blah, blah. So that at the end of your conversation, you can just look at everything that the scribe has done, edit whatever is wrong, and sign it. So essentially what you are doing is you are transforming the amount of time that you would have taken in writing or typing or putting orders and whatnot. You are pretty much endorsing it or outsourcing it to a medical scribe and using that saved time to spend more with the patient rather than with a computer. If something like that can be done in an Indian setup where you have a scribe sitting with your prescription pad, you rather talk to the patient and that medical scribe is just writing it on the piece of paper as you are talking, rather than a patient first getting screened with a junior doctor and later coming to you and you looking at it. Whether something like that can be done in India in real time, essentially there you will have a true FaceTime with the patient. and will be spending far less time in anything outside of it. Whether something like that can be done or not, I don't know. Billing also, I don't know. Certainly a lot more things that we need to learn as we go forward. Dr. Bipin, you have something to add? You raised your hand.
Yeah, thanks for the update, Dr. Anoop. I work in the public sector hospital in Jharkhand, basically a rural remote area, but have a bit of experience of working in Emmanuel Health Association's hospitals like Harbatpur Christian Hospital and one another in Bihar in Duncan Hospital, and some exposure in TMS Tata and other hospitals as well, for a few days only. What I have seen is thus we are coming with the National Digital Health Mission that the government is proposing. Then everybody is supposed to have a unique health ID, and like the Aadhaar card that we have with our demographic data. So National Digital Health Mission is proposing to have an integrated health data from, and it will be available to all the health personnel and everybody whosoever enters a private sector or a public sector. All their records are expected to be entered into that. So it will create a cloud-based server kind of thing, and we will have an access to their digital health records. But the thing is feasibility. If we see India is so vast, no? You cannot put something into one carpet and things will be done kind of. So we'll have to see what are the repercussions of it. But at the Emmanuel Health Association's hospitals where I have worked for some time, what I have seen is we document everything, and it is usually scanned and entered into the EMR. But copying that into primary care setup in private practice is not feasible at this stage, because in rural areas, no, billing is definitely a concern, and you can't expect people, if you are charging 800 for whatever procedure, they'll say ki I don't have the resources. First thing. Second is in Emmanuel Hospital Association, we had a consultant who there was one Marwari patient whose son was admitted, and that fellow was sitting with a laptop outside and discussed with our consultant for pretty length of time, sometimes somewhere around 20 minutes. So the moment the consultation finished, he wrote on the chart itself, ICU expert opinion for a time of 20 minutes, charge 500 extra more. So thing is, we are putting our resource, time is our resource, right? So if we are giving some time to some other person, and then we are cutting some time for another person. We are just, making a time differential for somebody else. We are cutting short on somebody's expectations and putting some on another one. So this way it can be managed, but for an OPD clinic, I don't think these are very possible in near future, like you said.
Thank you, Dr. Bipin. I think that these insights are very valid. And I started today's discussion by saying that I don't think we are gonna leave this room with more knowledge or education. It is just understanding how we are trying to adjust to this deficit, and hopefully come forward with some better ideas down the road, whether National Digital Health Mission will be the solution for it, or whether there is going to be more grassroots innovation, which some of us working actually on the ground will come up with an innovation. I don't know. But we certainly need an innovation. We need something which can improve how we interact with patients so that we can spend more time taking care of patient while not reducing our efficiency. I'll give you a very classic conundrum. Very commonly, a busy doctor won't be attending this kind of session because he's so busy to see his patients around. And even there, he may be or she may be putting 2, 3, 4 minutes per patient. So an hour of a discussion would essentially mean a 15 to 20 patients that he or she can see at that time. And that is the reason why people who should be a part of discussion will unlikely be a part of this discussion because they are busy taking care of the patients. whether they are providing good care or not. That I'm not judging, I'm just questioning whether that part is there. So a lot of innovation is needed where we can come up with a way where we don't kill their efficiency, that they may still be able to see 15 patients an hour or 20 patients an hour with equal efficiency that does not compromise patient care. So we are 10 minutes out of our scheduled time. Anybody else has got any other thoughts before we can start closing the session? Somaratu sir, I do have a question for you. Do you think this medical scribe kind of thing can work in India, where a person walks with me with a pen and paper and starts documenting everything that I'm talking to a patient in a prescription form? Do you think it is possible?
Not in the near future, Anoop. When I joined the new place where I am working right now, we had kind of pre-COVID era. We had around somewhere 283 patients I saw between 9 to 3. So can you imagine? I mean, what justice could I have been doing to them?
Right, absolutely. Somaraju sir, please, your comments about this medical scribe.
Anoop, thank you. I think it's possible in certain situations and certain type of setups we work. Certain setups, as Dr. Bipin mentioned, it may not be possible. But wherever it's possible, it's a good idea, and it should, when it can be implemented and when the system can afford it, it should be done. And before I go further, I request Prashant, who worked with us, to tell us what we're doing, what was right, what was wrong, what was ugly. You can just give a brief experience of yours as you worked with us, both in inpatient, outpatient, other areas. Prashant Vajirani.
Yes, sir. Good evening, sir. Yes, sir. What you taught us, as you were saying, you did not teach us just cardiology. You taught us the way of life, way of listening to patients. So what I learned new there, which I was not aware, even made aware in MBBS or MD, was that you have to listen. I was taught to listen to the patient, like so patiently. You were listening to all the patients, and sir personally used to see each echo CD of the patient. So normally what routine is happening, that bahar se echo somebody is doing and then we are just seeing the report and going. But sir used to come out of his room, see each echo CD, each views, and then he used to order for one patient. I remember 4 times he ordered an echo just to see that there was some small aortic membrane. So I learned so much from sir, and not only from sir, from other consultants also. Like they used to listen to the patient first rather than blabbering our own things and just asking leading questions. And for each symptom, you have to go in the depth. And even in the IPD also, during the rounds, sir used to auscultate each patient just for having that, building that connect with the patient. And I used to see that whatever the non-specific complaints were there, just after sir used to go and just put his stethoscope, those complaints just vanished. Like whatever placebo I was giving, everything was fine. And like it was a very new and very good experience, and I'm not seeing even 1% of it happening here in any of the hospitals in Ahmedabad. So I really miss, and whatever calls I get, I always tell all the other PG aspirants to go for especially Hyderabad, and I give reference of sir also to go and have some sessions with sir also. Thank you, sir.
Thank you, Prashant. And Anoop, if you have time, I'll just mention, and some of you already mentioned. So many of these things are easier once you work as a team. It should be more than one of us seeing a patient, whether a senior colleague of ours or junior colleague of ours, be part and parcel of your team. So more than one doctor sees the patient. And then there is a nurse clinician who also evaluates the patient. And this nurse also will have a follow-up telephone numbers and access so that the patients can be called as needed. And there is a nutritionist as part of the team, spends significant amount of time talking to them about nutrition. And one of the colleagues, physician assistants and others, talk about physical exercise or other things. And we see them as of now. Then also we have a flexible payment system where rich patients pay what they have to pay, and the poorer patient pays so-called, we used to have 2 types of charges. where anyone can afford it, and no patient is ever refused just because they can't pay. And we didn't charge another consultation when the patient comes within a 1 month's time. That was what we followed, and we continue to follow that. That worked for us. Thank you.
Thank you so much, sir. Thank you everyone for their insights. Praneeth, your closing comments for today's session?
Yeah, a very good discussion that we had, and I'm glad that we have a platform where these questions which or these topics which cannot be discussed in any of the academic forums that we have. I'm glad we have this platform and we could discuss this thing. Thank you so much for everyone for sharing their thought process, particularly Dr. Gauri and Dr. Bipin. And I believe just because we are talking, we'll be paying more attention that we have to spend some time. And once we keep looking at the innovations will come, the thought process will work. And hopefully we find a solution where we will be in a position where we are delivering effective healthcare to our patients. The FaceTime will be more effective and better healthcare being delivered. Thank you, Anoop.
Thank you, Praneeth, and thank you all of you for attending today's session, and thank you for sticking around for so long. We will be back next week with, I believe, a clinical topic for us to discuss. If any one of you is not a part of our WhatsApp group, please join. You can share your offline ideas there as well. And if you do have any topic that you think we should discuss on the huddle, please feel free to share that with us as well. Thank you all. Good night. We will see you next Wednesday. Take care.